morning meeting is advisory to this group, and this group is the group that has the authority to make the final decisions. So really, you're speaking to the top of the food chain right here.
Okay. Well, you know we've had beautiful testimony today.
Started being tapered 6 years ago when our first law went through. Even though we were grandfathered in, our Washington State Medical Association really looked out for chronic pain patients, and we have a legacy clause. And in our third law, that same group, the Washington Medical Association, they managed a Medicare exemption for people like me and the people you see here who are incurable, progressive. I have what's called cerulomyelia. It's a progressive tumor. Just had another MRI last week. It's doubled in size. It's not going to get better, ever. I've been through all of the treatments. Moved to Hawaii, been to 5 states, 2 countries, hundreds of thousands of dollars out of pocket, acupuncture, failed pain pump, all of it. The people in Washington had 50 surgeries. They're not going to get better, ever. And there's no more therapy for them. There's nothing more. They're lucky if they get a shower. They're lucky if they get out to their mailbox. You know, you don't see a lot of them here because they can't get here. I offered rides to a few. They couldn't get here. Washington State, I offered Uber, hotels. They couldn't do it. They get to the doctor. That's it. It's all they get. You don't see us because we're not out in the community. And to get here, I mean, these people have been here since 7:30. I mean, it's a hard day. Go be in bed. I would get here probably 2 weeks. And when I get home to Washington, it'll be the same. And my autistic son was just diagnosed with Ehlers-Danlos, which is a progressive condition as well, where his connective tissue will deteriorate, his brain may sink into his brain stem. Now these are conditions that, and there's a lot of them. I mean, even, you know, gout, CRPS. We have, you know, these laws. We have 5 patients, cancer patients in our Washington group that aren't getting pain management. A woman in hospice from Squim called me the other night. Her mom was cut off in hospice. 6 months to live. Her doctors, her oncologist is afraid to prescribe. I went through the Seattle Pain Center shutdown, the suicides. You know, we talk people down every night from suicide. I talked to a woman in Indiana. She has 9 inches of her colon on the outside of her body. She has no pain medicine. She was writing a suicide note on her sheet when I accidentally pocket dialed her in the middle of the night. So I mean, you got to think about these people. Not, you know, we didn't just bump our elbow and go on opioids. We tried all the triptylins. Got another friend, California. She's been hospitalized 4 times since January for GI bleeds from all of the aspirin and NSAIDs. Those aren't the answer. And we've got thousands, tens of thousands, millions of people who've been on non-escalating dosages of opioids for decades. I'm on half of what I was 10 years ago. And my son and I's life has deteriorated to hardly anything. So I need, you know, what they did in Washington was a mess. What they did with the CDC is a mess. They didn't even take in, both my son and I are ultra hypermetabolizers medication, which you guys never mentioned. CDC didn't, Washington State, you know. You and I aren't going to metabolize medicine differently. Amar and I aren't going to with our different diseases. We're all different. And to legislate away pain and legislate all these different diseases like they fit in a box is kind of ridiculous, really. I mean, it's not logical. It really isn't logical when you think about it. I was hit by a truck a half a block from my house. Years later, I slipped on a grate and was paralyzed for a year. I used to work for Congress. I used to work for the State House. I lobbied. Cabinet in a second. I used to sit on these kind of boards, not be at this kind of board. I wouldn't take part in something like this ever, because this is just wrong. And I wonder every day what history will, how this is going to go down in history. It's not going to go down well. Just think about the people that are chronic and incurable when you hear this.
So one thing I will mention is, and it was actually stated incorrectly this morning, we already have attached to the prioritized list a statement of intent on palliative care. So anything that this process ends up doing in terms of changes to opioid prescriptions would not impact palliative care services for patients with a life-threatening or serious progressive illness. So it's not just
So you're not
life-threatening.
counting palliative care at 6 months as in hospice like a lot of other states and insurance companies.
Right.
do.
That
That's
would not be.
is that going to be difficult for patients to get? Is that going to be a doctor's going to want to prescribe? 'Cause my doctor's a palliative care doctor, and he says he's on a national board. He says a lot of them aren't going to want to take this either. So it's still not the magic.
Well, it's good information to hear, so we're certainly going to take all this into
So
account.
think about with that palliative care, there's more to it and how, when I called Medicare last summer, they didn't even know how to spell it for me. They didn't even know what palliative care was. So when you write that, make sure the definition is spelled out.
Thank you.
Can I ask a quick question? I spent about 15 years working in medical research until I wasn't able to work anymore. And most of that time, I was able to work because of opiate medication. You have talked a lot about there is no evidence that shows that long-term opioid use is effective or that it, I'm wondering what evidence what studies are you basing this statement on, like the Krebs study, the Minnesota Krebs study that came out?
Well, you know what, I think we're going to have to move on to the agenda, but because that's really where we're going to, the time to ask that question and for us to address that is really going to be our next BBBS meeting, where we really kind of get into that deeper dive about evidence, what evidence is there, what evidence is not there.
If you want to go to our website and look at the Chronic Pain Task Force section, you can look at all of the meeting materials and all of the studies that were reviewed.
Okay, so it does show the,
You have to click on each meeting, but it'll show you.
okay, it will show what actual studies and evidence you're basing these statements.
Yeah, when we do studies, all the evidence base is put into the website, so if you have patients to sort through it all, you can find what all is there. It's the same stuff that we look at when we actually have to deliberate.
Thank you.
All right, so I think you guys get a taste of what's out there for us to address, and so we'll stay tuned.
on different subcommittees, and unfortunately I'm not sure that resulted in much. As a matter of fact, the only person I have to bring for your consideration today was known outside of that effort. So you know, there's still time. Hopefully we'll get some more interest. But for today, I've got for you Dr. Brian Duty, who's a urologist at OHSU, who is interested in serving with HTAS, and he represents a specialty that we've never had coverage for. We've certainly done things in urology in that subcommittee in the past, so presumably we will again in the future, and so it seems like a good fit. We checked his conflicts of interest, and absolutely checked out fine. He actually came as an audience member. He was the only audience member at the last HTAS meeting. So it was, nice to see that early engagement. So I ask that you consider appointing him to HTAS.
Okay. So that means we need to take a vote on that. So is any discussions? Anybody have any comments or questions about this membership to HTAS? If not, is there a motion to approve the appointment of Dr. Duty? Thank you, Gary. Second? Thanks. All in favor, say aye. Aye. All opposed, nay.
Okay. Thank you. One other thing is, forget which meeting it was, it might have been at the last VBBS meeting, there was a suggestion that we look at getting a ethicist consult for the future, and I did get Margaret Klein, who is currently with Portland Adventist, and she is also the chair of the Palliative Care and Interdisciplinary Quality of Life Advisory Council. She's also a registered nurse. She has actually kind of followed the Oregon Health Plan clear back from, she said she was at one of the community meetings back in 1990. And I, is that Leda?
Yes.
Hi, Leda.
Hi.
So this is Darren just giving my staff report. So thanks for checking in. We've got you noted for the attendance. And so, Jason and I actually met with her this week and kind of went through an orientation to fill in blanks about what she didn't know about the prioritization process, the coverage guidance process. Kind of gave her some overview of the different topics that the commission is working on. So we can, we definitely talked to her about the chronic pain task force proposal, and so suggested she look over those materials as we move forward with the process and consideration of that topic. And so we kind of officially got a on-call ethicist now as we move forward.
Great. Now that the scope of our work when it comes to certain costly and controversial drugs, now that scope has been kind of taken away from us, we have an ethicist to help us make that work. Yeah, we'll see. Yeah, we'll see what else comes up. I think that's great to have that backing.
That's all I had. And then Kat, were you gonna?
There's one topic that you previously approved as a coverage guidance topic that we would recommend you all to drop, and that is ECMO, the extracorporeal membrane oxygenation. So we started looking at that with the Center for Evidence-Based Policy, and just given the kind of evidence that's out there and the fact that this is a very high stakes and mortality situation, it seemed that it would be very unlikely that the coverage guidance would add much, and it didn't seem that it was worth the investment of time and energy to do a coverage guidance on that particular topic. So the recommendation is to drop it.
Do we need to approve that, or we just?
Yes.
Okay. So is there any concerns about removing ECMO from that list? If not, is there a motion to approve that recommendation? Okay, I can always count on you. Thank you. Second. Okay. All in favor, say aye. Aye. All opposed, nay. Thank you. Okay, BBBS, we had very busy. We got through a heck of a lot, actually, considering.
Okay, so, can you hear me?
I'm gonna take off. I'm just getting too sleepy.
Okay, good. So when we, what we'll be doing here is presenting the findings of the BBBS committee for your approval. We do have public testimony on one of the topics, I guess, maybe more than one of the topics. So what we'll do, and maybe we'll leave that topic for last so that we can accept the public testimony at the very end, and then we can vote from her perspective.
And that topic doesn't have anything to vote on today, so just informational for you.
Okay.
So we had our usual consent agenda table, but does anyone have any issues with what that pulled out? There was no discussion at BBS. And the other part of the consent agenda was some wording changes to the biomarker tests for cancer tissue, just changing the name of a certain test and adding line 660. Any questions or concerns there?
We can't think without our computers. She got logged out of her system.
Sounds like.
Yeah, so that was the consent agenda. We then went on and looked at the behavioral health.
Oh no, you guys aren't there.
Great, now it's logging me out of my computer. Apparently. We looked at the Behavioral Health Advisory Panel. They met and gave us various recommendations. They reviewed the ICD-10 codes that had to do with behavioral health advisory, which we'll talk about in a little bit. They looked at the inclusion of ER and hospital codes on a few lines that were essentially thought to be outpatient. God, I'm getting my own too much strength. Just do it.
I'm unsteady.
think too hard, I forget all my long stuff. You hear me? It's real. Yeah. It's funny, you can do it like with muscle memory, it just is fun. Okay, so let's just get rid of that one. Okay, so BHAP recommendations, they've added skills development and training to the abuse and neglect line. They removed inpatient ER codes from several behavioral health lines that were essentially outpatient only. They added neuropsychological testing to the PTSD line with a guideline stating that it's only to be used when there's a question of cognitive deficit or impairment, and such testing is required to make the correct diagnosis. They also added neuropsychological testing by computer or technician to the lines that had neuropsychological testing by psychologist or physician. They thought this was a better use of the professional's time to have a technician or a computer to do the testing, and then the professional would run the results. And then they also looked at unspecified mood disorder, which is F39, this diagnosis. There used to be a guideline restricting use, which was removed because we removed guidelines that restricted based on age unless we thought there was a good medical justification. Since that time, they've seen a large increase in use for F39. We did a data poll at the behest of BHAP to take a look and see not the vast majority, but 3/4 of those utilizations were done on 1 or 2 dates of service for a patient, and this was thought to be appropriate in terms of part of a diagnostic workup. A few had 30 or more dates of service, which may not be appropriate. The OHA Mental Health Division helped HERC staff come up with a new guideline note. BHAP thought the guideline note was appropriate, but they weren't sure if it was needed. BHAP actually never came to a consensus. Some felt that it was appropriate to use this in the way it's being used because it allows people to kind of get into the system. Others felt that it could be useful to have the guideline. DBS actually never came up with a decision.
This is for the F39. No, I thought we accepted your recommendation. We accepted the guideline. Yeah, we accepted the guideline.
Okay, so you. No, actually, the decision was to bring the guideline note to the medical directors and to see if it was useful, and then bring back in October for a decision.
Everything except that, okay.
Yeah. So everything other than the F39 unspecified mood disorder was approved as recommended by BHAP, as that specific topic was stated. I'm going to skip the chronic pain task force report for the moment. We'll do that at the end. I'm assuming that's what the testimony is. For our ICD-10 review, you all should have gotten an Excel spreadsheet in your packet. I also sent it to you individually so you can have a chance to review. So if you have any questions or you want any of those specific codes reviewed, I'm happy to review them. We did review several in detail. All of them were approved as recommended by staff or by BHAP. We had a more in-depth dive into brow ptosis, which is a sort of drooping eyebrow that can affect sight. The BBBS members had questions regarding some of the criteria for the adult acquired brow ptosis repair, and directed staff to work with ophthalmology to clarify this wording. So that was not approved. Ophthalmology, for those of you who don't deal with it regularly, has their own language. So I will bring that back to you in October with the wording, hopefully in a more understandable, clear format. And on a similar note, blepharopathy, which is drooping eyelid that becomes in the visual, there's also some questions about the wording of that guideline that we want to clarity. So I will look at all of the droopy parts of the face that can affect vision with an ophthalmologist and try to come back with more, how would you put it, non-ophthalmologic terminology. Then we went on to our biennial review. So these two topics will not take effect until January 1st, 2020. We have been working with a couple of dermatologists regarding severe acne, and the BBS approved the sort of final recommendation that staff and the dermatology group have come up with. So the recommendation is to add a condition called acne fulminans, which is a very severe form of acne, to the acne congoblata line, which involves adding the acne vulgaris codes to line 370, which is acne congoblata, and then adding a line to the guideline note about acne congoblata that says that L70.0, which is the acne series, is on that line only for acne fulminans. That specific change will actually take effect January 1st, 2019. We already have the acne congoblata line and guideline. It's not going to take effect October 1st because the P&T committee needs a little additional time to review the drugs that are involved so that they can come up with PA criteria. So that's one small piece. The much bigger piece is the creation of a new line for severe acne, which would take effect January 1st, 2020. The new line contains all of the L70 acne series and all of the procedure codes that are currently on the acne congoblata line. It would have a new guideline for severe cystic acne that would state that acne is only included on this new line if severe, defined as the presence of the following characteristics: persistent or recurrent inflammatory nodules and cysts, and ongoing scarring. Otherwise, acne diagnoses are included on line 520. Note that acne with recurrent abscesses or communicating sinuses is covered according to guideline note 133, acne congoblata and acne fulminans. The line scoring comes out to approximately line 451, which is just above the current funding line. Questions, concerns, discussion about the new acne line or about the acne fulminans change?
It's safe to say that it wasn't something that we came into the topic thinking needed to be addressed, but after testimony at our last meeting, that deeper dive was something that we all recognize needs to be prioritized. So.
And we recognize it will increase costs, but again, this will be delayed until 2020 to allow actuarial evaluation and any adjustments that might need to be done. The second biennial review topic is reorganizing our burn lines. This actually came from staff and BBS. The current burn lines use differentiation of burns based on sort of terminologies and differentiation that's kind of outdated. When staff looked at the lines, we realized that there were second-degree burns that were on an uncovered line and a few other concerns. So the staff recommendation, which was agreed, BBS also approved, was to consolidate the burn lines a little bit. We'll leave line 57, which used to be burn full thickness greater than 10% of body surface area, and we will just rename it severe burns. It will contain all of the third-degree burns, diagnosis codes, as well as complicated burns, which involve the trachea, larynx, etc., which need more intensive burn treatment. And it will continue to have all the CPT codes and picks that were on line 57 previously. There'll be a second burn line, which is a combination of the current lines 72 and 197, which will be moderate burns and contain all the second-degree burns. And it scores out to approximately line 127. And then there will continue to be the same minor burn line, line 602, and it will contain all of the third-degree burn lines. There's one additional burn line, which is for natural elements that involves like lightning strikes. That's because there's lots of other stuff that probably happens to you when you get those types of burns.
I actually had a question going back to a comment you said before you went on to the burn category. You mentioned that with the severe acne, it's kind of pending actuarial analysis and any adjustments that would need to be made. Can you explain what those adjustments would do for the work of the HER?
It doesn't do anything for her. So we are adding this benefit, which would allow almost entirely medications plus dermatology visits for people with severe acne. There's no coverage for acne currently, so that would be an increase in cost that the CCOs would need to provide. So the actuaries will just look at the CCO contracts and will adjust those contracts based on
incorporate this new benefit.
Exactly.
It's a rate adjustment.
Okay. It has nothing to do with us. We don't decide how much to pay them or anything.
Okay, and so whenever we take on something that we think is gonna have a major change in rates, then it has to be a biennial review topic, and so it gets delayed.
Or things like the burn line reorganization. It essentially has no change in coverage other than all of the second degree burns are now covered. A second degree burn usually would be treated with something like Silbadine, which is a topical medication. It may have different wound care kinds of things. A severe second degree burn might need treatment in a burn center or something, especially if it's related to something else. But essentially it has no cost, but we have to reorganize the list, so that's the other reason we make these kind of reviews.
Which is what I was just gonna say.
Yeah. Thank you. Any other questions about the biennial review topics? So then moving on, we looked at drug-eluting stents. These are sort of structures, tubes that you insert into someone's coronary arteries when they have coronary artery disease or patent MI to open them again. There's two kinds. One is a bare metal stent and one is a drug-eluting stent. The drug-eluting stents are significantly more expensive up front than the bare metal. But the research that we looked at showed that they have a lower rate of needing a second or a third procedure, needing to be opened again, etc. So the overall costs are some cost-effective analysis say that the drug-eluting stents are less expensive overall when you look at the entire spectrum of costs involved in the care. They're at least cost neutral compared to the bare metal stents. And our cardiology expert said that in the cardiology world, there's now very few indications for bare metal stents. There's a few things that they're good for specifically, but otherwise they're using these drug-eluting stents. So we put the HCPCS codes for drug-eluting stents on the 3 lines that have coronary artery disease as well as a complications line for coronary artery complications. We then looked at transnasal eustachian tube dilation. This is a procedure that you can put a stent into the eustachian tube, which connects the inner ear to the throat. The research shows that it's promising, but there was only a couple of studies available. It's not been compared to other treatments. It's just kind of this case series. We thought the conclusion was that it was experimental, and we placed it on line 660 with a note in guideline note 173. And we talked about the severe inflammatory skin disease guideline. This is a guideline regarding mostly psoriasis and eczema. The guideline has wording in there about when certain drugs are sort of our first line, when they're second line. The psoriasis medications kind of agree with current medical practice and PA criteria. The atopic dermatitis eczema portion doesn't really agree. And we had our dermatology experts help us with what's current standard, and we worked with the P&T committee to align this with their PA criteria. So the wording, a few of the orders and a couple of the drugs were dropped because they're not used anymore, and we changed some of the wording. So now it exactly agrees with our P&T criteria. The dermatology experts were in agreement with it as well. And then we went on to the PET scan guideline. There's several pieces of the PET scan guideline that refer to diagnostic testing, specifically for solitary pulmonary nodules as well as cervical lymph node metastases when you don't have an obvious primary. Because PET scans are on the prioritized list on multiple lines, and not on the diagnostic list. There's been problems in our system trying to get those diagnostic utilizations that it covered. So the solution that was approved by PBS is to change the PET scan CPT codes to the diagnostic list, take them off the prioritized list, put them on the diagnostic list, and change the current PET scan guideline to a diagnostic guideline. This essentially will have no change in how we are covering PET scans, but it will ease the use of PET scans for looking at solitary pulmonary nodules and cervical lymph nodes. We looked at absorbable implants for nasal vestibular wall stenosis. These are a very new technology. There was one small case series that we identified. This was felt to be experimental and was placed on line 660 with a note in guideline note 173.
Next, we talked about chronic migraines and botulinum toxin, or Botox, and essentially there's a guideline that requires you to fail three different types of medications prior to being eligible for botulinum toxin. And one of the medications that was listed in there actually doesn't have any evidence to support its use. That was calcium channel blockers. So we removed calcium channel blockers as one of the examples. And then there's also some discussion that there might be other medications that are effective for chronic migraines, such as riboflavin, which is actually a supplement, and magnesium. And so we thought that as long as three different evidence-based pharmacotherapy agents were used, that was appropriate. So that was modified. And then the other thing is we added that patients should be managed for medication overuse headache prior to being eligible for botulinum toxin.
We then looked at computer-assisted musculoskeletal procedures. This is essentially joint surgeries and using different types of imaging modality to determine where the implant, the arch knee or whatever, should be implanted. We reviewed evidence about various types of joint surgeries. The evidence shows that computer-assisted navigation for these joint surgeries may improve placement of the prosthetic immediately after the surgery, but it has no change in the long-term need for revision or any other functional outcomes compared to conventional surgery. It may be more expensive and it has longer operative times. It's not covered by any private insurers. So we elected to put it on line 660 with a note in guideline note 173 that there's insufficient evidence that it's effective. And then we talked about prioritization of FDA-approved drugs below the current funding line. And this is to bring OHA into compliance with federal rebate laws and other federal rules. So the changes that that PBS approved would be to remove the entries in guideline note 172 and 173 regarding buprenorphine, add the buprenorphine implant insertion codes into line 4 substance abuse disorder, and then have PNT create PA criteria for utilization of these buprenorphine implants and other buprenorphine products. We deleted guideline note 67 regarding enzyme replacement therapy. And we also referred this to PNT to create appropriate PA criteria to determine best. And then have PNT create PA criteria for utilization of these buprenorphine implants and other buprenorphine products. We deleted guideline note 67 regarding enzyme replacement therapy, and we also referred this to PNT to create appropriate PA criteria to determine best coverage of enzyme replacement therapy. And then we deleted several diagnoses for metabolic conditions that can be treated with enzyme replacement therapy from line 650. These codes all appear above the funding line. So they have other line placements that were not changed. We also looked at human growth hormone. So the recommendations are to add a very generic ICD-10 code, E23.0, which is hypopituitarism, which one of the subdiagnoses is adult human growth hormone deficiency. Add that to line 650 and leave on the current pituitary dysfunction. There's two different lines. And add a coding specification. The two covered lines, line 40, pan-hypopituitarism, and other pituitary disorders, and 386, which is pituitary dwarfism, will have a coding specification saying that E23.0 is included in this line for conditions other than adult human growth hormone deficiency. Line 650 will say that ICD-10 E23.0 is included in this line only for adult human growth hormone deficiency. This code can be used for many, many other diagnoses. And then we were going to modify Guideline Note 74 and remove the restrictions for the various types of growth hormone conditions that children need to have. Of note, idiopathic short stature, which is just a healthy child who's below 3%, 3rd percentile in the growth chart, that already is on an uncovered line. The guideline will have only one sentence left, and it will say treatment with growth hormone should continue only until adult height as determined by bone age is achieved. And then we'll strike the sentence about not including treatment for adult human growth hormone deficiency because of the coding placements that we changed. And then
next is diabetes prevention program. So this is a year-long community-based diet and exercise program for people with pre-diabetes. Previously, there have been some significant barriers because if they're community-based, they aren't necessarily provided in medical offices. But it's of considerable interest to the CDC and to other parts of the Oregon Health Authority. And so we added a series of codes to line 3, which is the preventive services line of evidence and effectiveness, and we added a guideline to clarify that the diabetes prevention program is covered only when it's CDC certified, so the CDC knows these rigorous certification criteria. And so this would enable payment to CDC certified diabetes prevention programs in Oregon as a potential licensed provider. And then because there are some issues just in terms of implementation, the decision was to delay it until January 1 of 2019 to allow the other parts of OHA and community members to continue to resolve those implementation concerns. The next one is this topic called coverage of developmental diagnoses, and essentially with ICD-10 changes back in 2015, schools and school districts provide a lot of developmental services for kids, and because of ICD-10 changes, all of a sudden they were submitting bills to Medicaid and not getting paid, and that's to do with some changes we made to where at least. Not that we made, but that OHA made. And so what we did here is we added some diagnostic codes, such as delayed developmental milestones, like Think Walker and Think Talker. We added those to the dysfunction lines on the prioritized list. And so the problem was before is that because these were diagnostic, kids couldn't get treatment with them. They could only get sort of a diagnostic workup. And so by moving a few of these codes into the funded region on dysfunction lines, it means that you would be able to receive physical therapy, speech therapy, occupational therapy, using these sort of global developmental delay and other codes like that. There was a bit of a discussion about one of the codes which was up for consideration, which is a little bit broader. It includes a wide variety of developmental delay diagnoses, but it also includes things like sensory integration or sensory processing disorder, which has been previously reviewed by this group and was chosen not to be placed in the funded region. And so a code was added into the funded region, but there's a coding specification that says for sensory processing and sensory integration disorder, these continue not to be in the funded region. Any questions on any of that?
And this will assist schools in providing the education, all the educational services and access that they're legally required to provide. We talked about revisions to the breast reconstruction guideline. We have a guideline that requires that women who undergo mastectomy as treatment for breast cancer or prevention of breast cancer in high-risk women should have access to breast reconstruction within 5 years of the initial mastectomy. we added a clause regarding revisions. So we also allow breast reconstruction for gender dysphoria, and there is a clause in the gender dysphoria guideline that restricts revisions of breast reconstruction to sort of medically necessary, non-cosmetic. We took that wording exactly and put it into the post-mastectomy breast reconstruction for women with cancer or at high risk. So this would then add this sentence: revision of previous reconstruction is only covered in cases where the revision is required to address complications of the surgery, parentheses, wound dehiscence, fistula, chronic pain directly related to surgery, etc. Revisions are not covered solely for cosmetic issues. We then, we skipped postpartum depression screening and cardiac MRI due to time constraints, so we'll be addressing those in October. Does anyone have any questions about any of these topics? There's one final topic, but we didn't vote on it, so I think we can go ahead and vote this report out unless people have concerns or questions.
Yeah, so from a procedural perspective, if we have a motion to approve the BPDS report that's been presented so far, we could get that off our desk, so to speak. So does anybody move to do that? Overlap it here. Okay. So moved and seconded. All in favor, say aye.
Aye.
Aye. Opposed, nay.
Aye.
Oh, thank you, Lena. I'll have to remember to wait for you to vote. And all opposed, nay. Great. So the next thing I think Earl's going to present is the topic from the BPDS where we heard from the chronic pain work group. Are you going to go ahead and kind of present the slides that we saw this morning, or how do you want to do that? It might be useful context in terms of helping understand the public testimony.
I mean, the only issue is that, you know, a formal proposal kind of hasn't been put together to bring to her yet, so it might be premature to do
No,
that.
I'm going to suggest we do it anyway,
Okay.
because I think that to the extent that everybody's on the same page about what's being discussed and what parts of it are discussed are creating nervousness in our community, I think it's helpful for everybody to be on the same page about that. But what we decided before the meeting was that this topic is one that's complicated. There's a lot of important public testimony that needs to be incorporated. So the committee's work isn't done, the task force work isn't done. And so we decided there would be no action item today. But this is, the fact that this is being discussed the way it is being discussed has created a lot of concern amongst the public. We're going to hear, I think, from some members of the community about that. And so rather than have to guess what they were nervous about, it might make sense to just show you what we heard this morning.
And then certainly if you've got input feedback that we can take back to the chronic pain task force, then we can certainly do that.
Okay, so the chronic pain task force has been meeting over the past year.
There's a slideshow here if you guys
Oh, yeah.
follow along behind you.
And they're meeting again in September, so again, any input that you have or questions or anything, we can feed back to them for their meeting next month. The any proposal that the task force comes forward with that you approve would be effective January 1st, 2020, because it's a biennial review topic. So the final endpoint of our timeline would be, this has to be approved for the March HERC meeting, but we do have a little bit of time to work on it. So this is just a reminder of who's on the task force. We have various disciplines that touch on the patients with chronic pain were included, and we had a series of public meetings. So their draft proposal that we looked at this morning would include 5 diagnoses, which are essentially chronic pain syndrome, types of chronic pain, and fibromyalgia, which are currently below the funding line. Would move them to a new line that would be in the funded region, but it would only move these 5 diagnoses. So other chronic pain diagnoses, that result in chronic pain, like rheumatoid arthritis or migraines, et cetera, would not be part of this this proposal. So currently, these conditions have no coverage by the prioritization on the list. In reality, we know that patients that have the ability to see their primary care providers and receive medications that don't have PA restrictions. So the proposal is to add a package of services to help these patients, and the ones that the task force have found to be evidence-based include cognitive behavioral therapy and also acceptance and commitment therapy, which is a very similar type of therapy. Acupuncture, health and behavior assessment, PT and OT, pain education, and then if CCOs are able with their flex funds to provide yoga, massage, exercise, etc., those should be included. And then this would also, if this line were approved to be above the funding line, it would be able to access all FDA-approved medications for chronic non-neuropathic pain, which would include NSAID, duloxetine, pregabalin, antidepressants, etc. In the guideline that the task force wrote to accompany the new line, it does require some type of active therapy, which could be psychotherapy, as well. Basically, monotherapy medications is not part of the package. So we asked the BBBS, and if any of you have anything to add, any thoughts about which diagnoses or which procedures are included? Definitely either bring them up now, you can always email me or otherwise contact me. Jason, go ahead. And then the task force wanted to link their new proposed chronic pain guideline to the opioid guideline that we wrote for back and neck conditions, to give them the same restriction as back pain. Just to remind you all, the opioid guideline for back and neck conditions restricts prescribing to 90 days after initial surgery or injury. The task force also, as just a general feedback to the HERC, felt that even if we don't make that change for chronic pain conditions, for back and neck conditions, that we should remove the word flare from the guideline, because there's newer emerging evidence that that opioids, either increasing them or short courses, is not the most effective therapy for a flare. That patients should have other types of treatments. This is just kind of an outline of what's on the current opioid medication guideline for back and neck conditions. And then the task force recommended that we consider requiring patients who have chronic pain and fibromyalgia to not be on long-term opioid therapy, and if they are on it, to require a taper. There's good evidence of harm for opioid therapy, including overdoses, falls, etc. Very low quality evidence of no benefit. There's some emerging evidence that opioids are no better than Tylenol or NSAIDs for back pain and fibromyalgia. It's a new and emerging field. There is better evidence for no benefit for opioids for fibromyalgia, and very limited evidence of good outcomes of taper programs, but again, that's also an emerging area of the literature. We did get a large number of patient and provider, a large number of written testimony. What you see on the slide there is a staff summary of the main themes. It's no means a complete distillation of every testimony, but kind of the main themes that we're seeing. People saying that alternative therapies are either not adequate by themselves or they don't work. Benefits of long-term opioid therapy for function and improved ability to work or care for self or family. Harms of involuntary tapers from long-term opioid therapy, including reduced function, increased pain, increased risk of suicide, increased use of illicit opioids or other drugs. Statement that patients on chronic opioids are not addicts. Proposed taper policy being an overreaction to a few bad patients or doctors or illegal drug users. Stories of personal bad experiences with forced tapers. A feeling that opioid tapers should be decided between doctors and patients and not by payers. And then some comments about this being a discrimination against low-income patients or low-income patients. So any questions or feedback or thoughts, particularly for the task force when we meet again? And again, if you go home and come up with a burning question or issue, feel free to email me.
I had a question about how the committee accepted the argument that this might discriminate against low-income people or people using OHP.
So response I didn't hear a specific response. There was some thought that we already are discriminating against OHP patients by not allowing them access to acupuncture or certain drugs or cognitive behavioral therapy, which a Blue Cross patient or someone would. So this in some ways is bringing equity to the OHP population. We didn't specifically address the inequity that would result with opioids.
Well, to be fair, I mean, so I think it's fair to say we set a record for public testimony in one of our meetings, at least since I've been on this group. So what we decided to do was to spend very little time talking as a group about what this means and really just listening to the public. And we made the decision before the meeting that we weren't going to decide anything, just so that we had more time to digest and let the task force also incorporate this public feedback. So I think one of the things that we tended to hear from just about everybody, both on the written and in the verbal testimony, was that there was great support for adding all of the other adjunctive things, non-opioid things that would be covered now that wouldn't have been covered in the past. But there was, and we'll hear, I think, from some folks that doesn't always work, and when there's not a long-term opioid, or when there's the risk of reducing opioids, is what's really got people fearful. When you've been doing fine on a stable dose of opioids for a long time, and you start to taper because of public policy, that has people very, very nervous. So that was really a lot. I think we'll probably hear some more of that. So we didn't really talk at all. We just asked a few questions and waited to make a decision on this down the road.
And so certainly much more discussion to come when it does come back to BBBS after the Chronic Pain Task Force spends some more time with it. So that could be at their October meeting, could be at the November meeting. And again, as Ariel said, we've still got time before a decision needs to be finalized by March.
So this might be a good time for us to accept public testimony on this topic. If there are folks who are interested in testifying for this group, I think we have comments that I signed up to. Great. So we hear from you. Come on up.
Our general policy is we ask for the record if you state your name and any affiliation you might have that you're speaking on behalf of, and then if you have any conflicts of interest in what you're about to, in your testimony.
And then I'll give 60-second and 30-second at times of indication.
Okay, well, my name is Mike. Can you hear me?
Yep.
I can't hear me.
Yeah, it's okay.
Not in the hearing aid. My name is Tim Harless, Harless. I'm 68 years old. I'm an advocate of the American Chronic Pain Association. We do support groups for people with chronic pain. I found that out of necessity after the VA cut me off my meds with a zero policy. I don't need this. Excuse me, Dr. Jack.
It's hard to hear you in the back, Tim, though.
Okay, I will put up.
Much better.
It also helps in recording.
Yeah, okay, that's fine. Anyways, my issue started in '86. I fell off a road. 22 feet to asphalt. Shattered my ankle. All of a sudden, I had a host of issues I was born with. I didn't know. I was a hot car roof. Construction all life. I abused my body working in it. Life scoliosis, my stenosis, my degenerative disc disease, all showed up and started dancing and giving me issues. In the 90s, I started going through private care practice. My wife worked at the time, had insurance. We now are raising our grandchildren. She can't work. So I had to go to the VA. And that's a long story, but regardless, we all know that VA has a zero policy. They did me a lumpectomy in 2011 to take care of the stenosis that was killing my leg nerves and my feet nerves, which caused me neuropathy. There is no cure for neuropathy. I just had surgery, reconstruction of my lower lumbar on February 23rd, and on July 13th, I had a C6, C7 disc replacement that VA screwed up 2 years ago. The reason for these two surgeries was to get rid of the pain in those two areas. I've been living with them since 2000. I now am happy to report that the doctor at Magic Hands, my pain, constant pain, is not at a 7. It's at a 2, both in my neck and my lumbar. And that's wonderful. And I'm opiate free as we speak, not out of my design. Okay. So, I end up going back with the opioids. I'll just maintain my own thing, and I'm doing that, and I'm not doing that much with the neuropathy pain. I quit drinking 15 years ago because I can't do it and do my meds, all right? I don't want to go back to drinking and be an alcoholic, because that's what it would take to knock back the pain, knock myself out. Now, what works for me is time-release morphine. Flare-ups is only because I decided to do something that day that was a little bit too much more than I should be doing, like sitting on hard chairs most of the day. Tears me up. Now, my only reason for bringing this up is because I'm 68 and I'm mad at the VA. I'm probably going to end up on the Oregon Health Plan, all right? And then this will really affect me. I'm going to leave you with some quick comments and just have to give you a history of who I am and what's going on. My thoughts about this whole thing is A, this state has a death with dignity law. There's been a 30% increase in suicides for those who live in chronic pain. That study from Dr. Blanky up at OHSU for 2015. Oh my God, in 2018, I'm sure those numbers have increased. Now, that being said, I'm not suicidal, I'm not homicidal. I'm beside myself with thinking that with this state having a death with dignity, how can we have no life with dignity? Just think about that. The irony of that situation. Doesn't that just stop you for a moment and go, wow, wait. It should. You all have the opportunity to really impact people's lives here. For the better or for the worse. Now, I'm serious. I told you I am for people with chronic pain and also for people who want to have support groups and we can sit around and talk. I can tell you of people I've talked to within the last 2 weeks who were suicidal. This is serious shit. Pardon the expression. I wanted to leave you with that, okay? Thank you very much and have a great day.
Have one more person.
Just one?
I'm Karen Yerdane. I'm from Prineville, and I have been a public health nurse for 30 years. Those who have Oregon Health Plan. I commend that. The more options, the better. The more options that people have, the lower we're going to bring their pain and the less need for opioids. However, for some things, even with all the modalities that I can use as an employed person with private insurance, I still rely on opioid therapy every day to be upright, to work, to be talking to you guys. One of the big public health pushes right now is health parity or health equity. Looking at cultural conditions, looking at health conditions. What are the different things that impact how accessible a person, what are their access to things that can keep them healthy, whether it's food, whether it's a place to live, or whether it's health care. I would encourage you to, yes, put these other things above the line. I would strongly encourage you not to take away the opioid option. Hopefully, the need for that will decrease some, but it does not go away, and for some people, it is what keeps us upright and working. Without those daily opioids, for me, I would no longer be a public health nurse. I would no longer have private insurance. I would no longer have my home. There's a lot of people that are already on the Oregon Health Plan that still work and can maintain that, be less of a burden on society. You know, the state budget, because it comes down to that in some aspects, because they can handle opioids as part, not all, but part of their therapy. If we take that away, we decrease people's ability to work, therefore we increase the reliance on public benefits, and that increases our costs as a state. Not only, you look at that, and then you look at the humanitarian part of it, less ability to be a family member, to be a community member, to be, a person living well. And we, in public health, have a program called Living Well with Chronic Conditions. So I commend you on putting many of these things above the line that will help that. Please don't take away one of those options that are there right now. We are losing pain doctors. We have people that are afraid to prescribe. They're afraid of losing their license. Thank you. I'm going to take experts. Thank you.
And I think it's fair to share that out of a significant number of the testimony this morning came from providers. Most of them weren't affected by chronic pain, but were echoing some of this. The people who cared for those in the chronic pain community for a long time. So we'll be hearing more about this. A lot of the questions or concerns came about from the community came about how do they stay engaged, how to make sure we don't make a decision behind closed doors. And I think we're pretty successful at helping direct them as to where the next meetings are and how everything's going to be done in the live day and public meetings. But there was a lot of nervousness that this will just kind of get handled behind closed doors, which is how we operate. So,
quick question. So we planned this out and try to make sure everyone we were told would do the testimony at the morning meeting, so that's why there's not a lot of people here today.
right.
So we would have prepared more for this if we knew that was an opportunity.
Actually, that's what we wanted.
Yeah,
we want to wait
Okay.
until the actual proposal comes to this commission for a decision before we hear more testimony, because then at that point you'll be able to see what the final proposal is and be able to testify on that.
One more question. Will you all be able to read the comments that were sent to the VVBS, the HERC members?
Yeah, we provided those.
Okay.
Yeah.
Thank you.
The recommendation is coming from the Oregon Opioid Task Force?
The Chronic Pain Task Force.
Right. Now, that task force doesn't have a member of the chronic pain community on it, like Governor Brown promised. How can that be?
We have a patient representative on that group.
Yeah, that one gal who works as she works in the industry and she's in pain.
She no longer works in the industry.
Because of her pain.
Oh, she's
There's no conflict of interest, is what I'm saying.
No, she's not currently a part of that. She does not receive money as a provider of any sort.
Okay, so then you guys just brought her on board. You got her vetted.
She's attended all the meetings.
Huh?
She has attended all of the task force meetings, I believe. We also
Okay.
had public testimony. We had patients come to at least one of the task force meetings and give testimony.
And I think there's six members of the task force that regularly treat pain patients.
Okay, well, my big question is how can we influence them before they make a decision?
They're public meetings. So they come and give more testimony and provide written testimony as well.
Yeah, okay.
One of the things I was trying to explain is that group is advisory to VDBS, our morning meeting, and our morning meeting is advisory to this group, and this group is the group that has the authority to make the final decision. So really, you're speaking to the top of the food chain right here.
Okay. Well, you know that we've had beautiful testimony today of professionals from within the industry, the pain industry, and I'm almost feeling you guys have enough information, but I fear you don't.
third law in Washington State. I was started being tapered 6 years ago when our first law went through. Even though we were grandfathered in, our Washington State Medical Association really looked out for chronic pain patients, and we have a legacy clause. And in our third law, that same group, the Washington third law in Washington State. I was started being tapered 6 years ago when our first law went through. Even though we were grandfathered in, our Washington State Medical Association really looked out for chronic pain patients, and we have a legacy clause. And in our third law, that same group, the Washington Medical Association, they managed a Medicare exemption for people like me and the people you see here who are incurable, progressive. I have what's called cerulomyelia. It's a progressive tumor. Just had another MRI last week. It's doubled in size. It's not going to get better, ever. I've been through all of the treatments. Moved to Hawaii, been to 5 states, 2 countries, hundreds of thousands of dollars out of pocket, acupuncture, failed pain pump, all of it, all of it. The people in Washington have had 50 surgeries. They're not going to get better, ever. And there's no more therapy for them. There's nothing more. They're lucky if they get a shower. They're lucky if they get out to their mailbox. You know, you don't see a lot of them here because they can't get here. I offered rides to a few. They couldn't get here. Washington State, I offered Uber, hotels. They couldn't do it. They get to the doctor. That's it. It's all they get. You don't see us because we're not out in the community. And to get here, I mean, these people have been here since 7:30. I mean, this is a hard day. They'll be in bed, I would guess, for probably 2 weeks. And when I get home to Washington, it'll be the same. And my autistic son was just diagnosed with Ehlers-Danlos, which is a progressive condition as well, where his connective tissue will deteriorate, his brain may sink into his brain stem. Now these are conditions that, and there's a lot of them. I mean, even, gout, CRPS. We have, these laws. We have 5 patients, cancer patients in our Washington group that aren't getting pain management. A woman in hospice from Squim called me the other night. Her mom was cut off in hospice. 6 months to live. Her doctors, her oncologist is afraid to prescribe. I went through the Seattle Pain Center shutdown, the suicides. We talk people down every night from suicide. I talked to a woman in Indiana. She had 9 inches of her colon on the outside of her body. She had no pain medicine. She was writing a suicide note on her sheet when I accidentally pocket dialed her in the middle of the night. So, I mean, you got to think about these people. Not, we didn't just bump our elbow and go on opioids. We tried all the triptylins. Got another friend, California. She's been hospitalized 4 times since January for GI bleeds from all of the aspirin and NSAIDs. Those aren't the answer. And we've got thousands, tens of thousands, millions of people who've been on non-escalating dosages of opioids for decades. I'm on half of what it was 10 years ago. And my son and I's life is deteriorated to hardly anything. So I need, what they did in Washington was a mess. What they did with the CDC is a mess. They didn't even take in, both my son and I are ultra hypermetabolizers medication, which you guys never mentioned. CDC didn't, Washington State, you and I aren't going to metabolize medicine differently. Amar and I aren't going to with our different diseases. We're all different. And to legislate away pain and legislate all these different diseases like they fit in a box is kind of ridiculous, really. I mean, it's not logical. It really isn't logical when you think about it. I was hit by a truck a half a block from my house. Years later, I slipped on a grate and was paralyzed for a year. I used to work for Congress. I used to work for the State House. I lobbied. Cabinet in a second. I used to sit on these kind of boards, not be at this kind of board. I wouldn't take a part in something like this ever, because this is just wrong. And I wonder every day
We need to move on with
what
our-
history will, how this is going to go down in history, because it's not going to go down well. Just think about the people that are chronic and curable when you hear this.
So one thing I will mention is, and it was actually stated incorrectly this morning, we already have attached to the prioritized list a statement of intent on palliative care. So anything that this process ends up doing in terms of changes to opioid prescriptions would not impact palliative care services for patients with a life-threatening or serious progressive illness. So it's not just
So you're
life.
not counting palliative care 6 months in hospice like a lot of other states and insurance companies.
Right. That would not.
Is that going to be difficult for patients to get? Is that going to be a doctor's going to want to prescribe? My doctor's a palliative care doctor. He says he's on a national board. He says a lot of them aren't going to want to take this either. So it's still not the magic.
Well, it's good information to hear, and so we're certainly going to take all this into
So
account.
think about with that palliative care, there's more to it, and how, when I called Medicare last summer, they didn't even know how to spell it for me. The rest didn't even know what palliative care was. So when you write that, make sure the definition is spelled out.
Thank you.
Can I ask a quick question? I spent about 15 years working in medical research until I wasn't able to work anymore. And most of that time, I was able to work because of opiate medication. You have talked a lot about there is no evidence that shows that long-term opioid use is effective or that it. I'm wondering what evidence what studies are you basing this statement on, like the Krebs study, the Minnesota Krebs study that came out?
Well, you know what, I think we're going to have to move on to the agenda, but because that's really where we're going to, the time to ask that question and for us to address that is really going to be our next BVBS meeting, where we really kind of get into that deeper dive about evidence, what evidence is there, what evidence is not there.
If you want to go to our website and look at the Chronic Pain Task Force section, you can look at all of the meeting materials and all of the study review.
Okay, so it does show the.
You have to click on each meeting, but it'll show you.
Okay, it will show what actual studies and evidence you're basing these statements.
Yeah, when we do studies, all the evidence base is put in to the website, so if you have patients to sort through it all, you can find what all is there. It's the same stuff that we look at when we actually have to deliberate.
Thank you.
All right, so I think you guys get a taste of what's out there for us to address, and so we'll stay tuned.
And then have PMT create a PA criteria for utilization of these buprenorphine implants and other buprenorphine products. We deleted guideline note 67 regarding enzyme replacement therapy. And we also referred this to PMT to create appropriate PA criteria to determine best coverage of enzyme replacement
want to prescribe. My doctor's a palliative care doctor, and he says he's on the national board, he says a lot of them aren't going to want to take this either. So it's still not the magic.
Well, it's good information to hear, and so we're certainly going to take all this.
So think about with that palliative care, there's more to it, and how, when I called Medicare last summer, they gave me an Ida form. So I didn't even know what palliative care was. So when you run write that, make sure the definition is spelled out.
Thank you. Thank you.
Can I ask a quick question? I spent about 15 years working in medical research until I wasn't able to work anymore. And most of that time, I was able to work because of opiate medication. You have talked a lot about there is no evidence that shows that long-term opioid use is effective, or that it. I'm wondering what evidence what studies are you basing this statement on, like the Krebs study, the Minnesota Krebs study that came out?
Well, you know what, I think we're going to have to move on to the agenda, but because that's really where we're going to, the time to ask that question and for us to address that is really going to be our next BBBS meeting, where we really kind of get into that deeper dive about evidence, what evidence is there, what evidence is not there.
If you want to go to our website and look at the Chronic Pain Task Force section, you can look at all of the meeting materials and all of the studies that were reviewed.
Okay, so it does show the...
You have to click on each meeting, but it'll show you.
Okay, it will show what actual studies and evidence you're basing these statements.
Yeah, when we do studies, all the evidence base is put into the website, so if you have patients to sort through it all, you can find what all is there. It's the same stuff that we look at when we actually have to deliberate.
Thank you.
All right, so I think you guys get a taste of what's out there for us to address, and so we'll stay tuned to
hoping to show them that we're not going to sit quietly and allow them to do this. This is a quality of
in case you were wonder. And I would like to introduce, hopefully, our next governor, Patrick Starnes, and thank him and his wife Mary for coming out here today and for putting the work together with us.
Yay!
No, but I just want to thank everyone for inviting me. I really don't have a voice, and I hope to be that voice as an advocate for you. Especially, I'm going to talk about three important things that you probably already know about. But the fact that you don't have a seat at the table, and that you're not, they have a chronic pain task force, which is not why we're here today, but you have a chronic pain task force, and a chronic pain patient is not on that task force. What's wrong with this picture, right?
Yeah!
It's like, or at the minimum, where's your doctor? Why can't they be at the table for you, speaking for you? So that's an important reason I'm here. The other reason is because we need to de-link the issue of addicts, which is an important issue, to chronic pain sufferers and chronic illness sufferers. And my final point, which I was talking to Connor at the Statesman Journal about, is as a candidate for governor, my whole campaign is about getting big money out of politics. And this, and people across the state, across the political spectrum get that. The conservatives in Eastern Oregon, the liberals in Eugene, everyone gets this issue, and that's why we have the common ground that's going to go around our campaign. And this issue right here is an exact example of this issue, right? Yeah. Because if you follow the money and you dig deeper, and that's what we're asking the journalists to do, to follow the money, dig deeper, and see what's going on with the big money, big pharma, that is wagging this dog, right? And you guys are going to be the victims of that, and that's not okay.
Yeah!
So I'd like to invite another speaker up. I haven't told her, but Amara, did you want to say?
Please, Amara.
If your pain does not allow you to speak, please. But we want to hear everyone have a time. Thank you so much for inviting me.
Thank you, Patrick. Vote Patrick Starnes.
Thanks so much, everyone, for coming. I know that it's taken me ignoring my kids for 3 months to get this information about this new task force. Oregon Health Plan members shouldn't have to dig around for 3 months and discover this stuff on their own and then not get calls back, not get responded by HERC, to have to wait to tell other people that are relying on you for this information, I'm sorry, I still don't have this information on how to comment or how to testify on our behalf. To say no, this policy change has been done in the dark. This proposed policy change has been done in the dark. It's been done with no transparency, and that's not okay. And just because we're disabled and we may be low income, that doesn't mean we are any less valued. And we deserve our health care. And thank you so much for being here.
Thank you, Amara.
I want to talk.
I'll say something.
I think it will be feedback. Stephen Hicks, I believe you live in Albany, right?
Yeah.
That's another great thing. Folks are from all over the state, the Willamette Valley, not just Portland, are speaking up for their issues.
Thank you, everybody. My name's Stephen Hicks. I'm here for so many others that can't make it here. That people are desperate and they don't know what to do. I am here to tell everybody, if anybody needs to have an ear to listen to them, just to be able to relate that they are not alone. That's what we're here for. We advocate for you. I could not do this for myself. I am doing it for everybody. Sooner or later, this will affect everybody in our country. My life was changed in the blink of an eye. The blink of an eye is all it takes. And with these type of toxic policies that are being tried to be passed and done, but with nobody knowing what's going on, it's just absolutely ludicrous. We're not asking for anything more than some quality of life so that we can have a life that, so that I can be a better father, I can be a better husband, I can be part of society. My life now is the cell of my bedroom. I live most of my life in bed because I cannot move. It's a very serious problem we're having. Everybody is scared to death. Doctors are scared to death. The only people happy about this are drug rehabilitation people and pushers of Suboxone and Uniprofene. And the idea that somehow our pain is going to magically go away with aspirin or Tylenol or any of those NSAIDs or whatever the hell they're called, it's simply untrue. If you put the word crisis behind any word, it can make it real scary. When you say opiate or opioid, that means strong medicine for people that are suffering with extreme, severe pain. That's it.
Quality of life.
Street drugs are the real problem. People are dying of heroin and fentanyl and many other street drugs in combination. The idea that our community is giving our medication to children so that they can kill themselves by ODs is absolute insanity. Every person I know in chronic pain is very tight-fisted with their medication because they need their medication. I'm so proud of everybody who came here today. I look around and I see people who are suffering, like me, and they still came here. That's how important this is. Our human and civil rights are being violated as we speak, and somehow they're trying to make it okay. It's not okay. Please, everybody, we only have one person that is our ally, that is running for governor. Patrick Starnes is our ally. We have an ally that's running for governor. Hallelujah.
Amen. Amen.
Thank you for your service to all of you. I love you all from the bottom of my heart. Thank you.
Love you, Steve.
One love, Steve.
One love, one love. One love.
So I know exactly what I'm going to say. It's great to see all of you guys here. I mean, it's great. It's great to have a group of people that is working on this together. I have personally seen a lot of devastation and destruction. And so, you know, we are literally collateral damage. Oregon is literally on the chopping block. And this is not just a Medicaid issue. This is going to spread to all other insurance companies as well. So we are all in danger here. And I personally, my mom has been taken off of her medication for no reason whatsoever. She has documented medical conditions. I can show you her MRIs, her MRograms. I can show you where it says that she has debilitating medical conditions, but yet she was given no choice. The doctor said, I'm taking you off your medicine, or you can say you're an addict. If you say you're an addict, I'll give you Suboxone, but that's your only choice. That was her choice. That's an ultimatum. I believe that that's blackmail and coercion, and I don't appreciate that for my mother, and I don't want it for any of us. This is where we're headed. We have to have our voices be heard, and this is one way that we do this. We all have to start speaking out, because that's the only way that we're going to humanize ourselves to everyone. You know, the government, the media has done a great job of promoting the opioid crisis and making the chronic pain patients synonymous with addicts. We are not addicts, but when anybody hears opioid crisis, they automatically think chronic pain patients and it equals addicts. And that has made our voices muted. When we talk about our medication being taken, they automatically think, well, they're addicts fighting for their drugs. That's what people think. That's the public opinion right now. We have to change that. We have to get them to see we are mothers, fathers, brothers. We are people. And the policies are making it so that we can't even function. We don't even have lives that have any kind of quality to them. Because they were taken from us because our medical conditions are not being treated. We are being abandoned medically. So we need to humanize ourselves. We need to do more of this kind of thing so that people see us. And they notice the difference. We're not addicts. We're pain patients. We don't choose to be in this position. We're trying to make the best of what we've been given. We're trying to, take whatever medication that we have so that we can live the best quality of life for our families, for our community, for our neighbors. We want to do that. We don't want to take medication. If there was another way to do it, we would. But this is our only option. So I'm so happy to see all of you here. And let's continue our fight. Let's be heard. Let's let people understand that we are human beings and that their policies are drastically affecting our lives and causing damage to our families and to everyone around us that we impact. So, thank you.
I'd like to reinforce what she's just said about the choice. This is not a recreational drug issue, right? I mean, no one here is volunteered for this chronic pain. As you can see across the place here, there's a date when that injury happened, when that bad surgery happened. And these folks have not chosen to have this pain. They haven't chosen to do these drugs. And what I've also learned is that when they are on the pain medication, it's not enough. They're still suffering from pain. So,
I just wanted to say something real quick about, I don't know if everybody knows exactly what they're doing here with the policy changes, and I brought it up to some people and they were surprised. So I just wanted you to be aware of what they plan on doing is eliminating opiates for any chronic pain condition and force tapering everybody who's on opiates in the Medicaid program, which will transfer to the CPOs and the other insurance companies, and replacing it with, if available, alternative therapies such as physical therapy. I think chiropractic's out, acupuncture, and said he has a point there that most chronic pain patients that have been in chronic pain for any amount of time have already tried these therapies, and they don't work standalone. They are not evidence-based. They are not a replacement for opioids. My own condition, I use several different, my protocol's complex. I use non-steroidal anti-inflammatories. I use steroids. I use nerve pain medication, and the last thing I use is opiate therapy. And without that, none of those other things are going to work. And so that's what they're planning on doing, and also cognitive behavior therapy and things like that, mindful, which is all good. All these things are good, but they're not a replacement for opiates. And we've all tried these kind of things. I certainly have. So I just want to make sure that people are aware that, and they also have the power to do this without our comment, or even, I believe they have a waiver through CMS right now. I'm checking into that, that allows them to implement these policies without any voting or anything. They just go into effect. So us being here and speaking out about it is really important. And thank you everybody for coming. I know Steve does this at great expense and is such an awesome person. And everybody here with invisible illnesses that people walk by every day and don't know that they have these chronic pain conditions. This is getting the visibility out, and I just want to thank everybody for coming.
Good job, Eve. Thank you. Would you like to speak? Tim, did you want to speak? Yeah, let's hear from all the people that aren't actually suffering from chronic pain, but are the supporters and the caretakers of the chronic pain. So they're indirectly, their whole lives have been changed too.
Hello? Hello, my name is Zane Davis. I lived with my dad who's been disabled my entire life. And I only have one message for you all. The government needs to take its hands out of the doctor-patient relationship.
Amen!
Short and sweet, that's a good message. Look at the date on this one. I know you guys have been suffering for a long time, but over 30 years, a roofer who fell off a 2-story roof, and I know the list of accidents and injuries, you know.
Thank you much, Patrick. And again, Patrick, I want to thank you from the bottom of my heart that you are here to help voice our issues. Our issues are shelved back and put on the back page. It even makes the news anymore. It seems as though, just like I've heard said, and I'm here repeating, that chronic pain patients have a stigma attached to them everywhere from your doctor to the pharmacist to your social, your friends and neighbors, and church members, and everybody else who is around you is impacted by the stigma. And whether they think that, yeah, you know, he's okay, he's up and walking around, or gee, he used to be so vibrant, how come he can't do that no more? Because it is an invisible illness. You can't see that, you know, it's not like I'm missing, you know, leg, or my leg was smashed, and I have problems with the bottom of my feet. Nobody can see that. Nobody can see all the padding I have in these diabetic boots. I'm not diabetic. This is what I have to have in order to walk around. And I can't walk very far. And if I was to use opiates, because I'm right now, thanks to the VA, free opiate period, which means that I'm having issues. So we won't go there. My big statement is simple. And to echo Zane, we have people who are background with addiction services trying to make legislation without voting about what we are supposed to do with our chronic pain. I fail to see how somebody without a medical license, without going through all the schooling for a doctor, and even doctors have to have a pain specialty arena to really know how to deal with chronic pain. But we have people who are not even qualified to do that, and they are trying to tell us how to live without chronic pain, which means they are saying opiates are bad, no more opiates. That's their opinion. Their opinion should not be turned into legislation. That's pretty much all I have to say. Thank you.
Well, if you get into the details and some of the history, I'm going to put a guy on the spot. Joseph, would you tell us about how this started off with the governor's panel being a 24-member panel, but now it's whittled down to a hand-picked 6-person panel? Can you give us some of the history?
Okay, briefly, last year the Oregon legislature passed some opioid bill, House Bill 3440. As part of that bill, as it was first presented, they called for an opioid task force of 29 members, and it would have been a very fair and balanced task force. It included all the usual characters about with addiction and the law enforcement and so forth, but it also would have included a doctor who specializes in pain, a chronic pain patient, and a member of the ACLU. However, that portion of the legislation was chopped out before final approval so that Governor Brown could handpick and appoint a much smaller, a 16-member task force. I hear that there's 2 more members now, but not to our benefit. And this task force is addiction specialists, law enforcement, and some people who the minutes of the meetings have shown are virulently anti-opioid and zero tolerance pain medicine people. So that has been a big bugaboo of mine lately. They had a chance to present all the stakeholders involved, including us, but they chopped that out in favor of a biased group, which is writ large. That's what's happening on the national level and all over the pain. As our gubernatorial candidate here pointed out, the pain voices are locked out, not invited to the table. So, and I, for one, am really sick and tired of the stigma, and I'm tired of reading about yet another suicide among us, and heart attacks. Yeah, the people who have died as a result of this crusade and killing themselves just because they can't stand the pain anymore. Their medicine's taken away, and these folks have no idea what it's like to live in pain 24/7. It gets to you after a while. And there was even that woman in Montana not long ago, a former police officer, who killed herself. She hadn't even been lost her meds yet. She was just burned out on the terror, the constant terror that we have. It is enough to live with pain in our bodies all the time and to cope with the sleeplessness, the depression, the constant pain, all these aspects of our own pain without having to live in constant terror as the governments, state and local and federal rather, are waging terror upon us. And it's enough. It's really exacerbates things. So, okay, I'll shut up.
But thanks for the history. And in closing, I think we want to talk about, no, we won't hear from you. We want to, after you, we want to talk about what's next, right? There's some important dates coming up. And also we've talked about the sponsor of the previous legislation. We need to find out who that ally was, because that's something that's going to stay in there. I'm with a lot of it. But we'll get an advocate that they could be your champion in the state house. So.
I'd rather stay on this because I work for the government. I'm in a position where I review medical records all day, every day for the government. I don't have a pony in this race, but I read how people get addicted in the first place through no fault of their own. But the thing I really want to say to Jeffrey Rose is I read medical records every day of people who are compliant, they are not addicted, they're not diverting anything, and they need these medications to get by. They can't do it without the medication. And I'm going to have my sit down with him and tell him all about that.
Amen to the whistleblowers, right? Yeah. So, Julia, or Amara, can we talk about what's next for us with these deadlines and these dates coming up? Because I don't know if everyone knows.
And it's always developing, just us finding out more and more about this commenting period. We have HERC is having their meeting on August 9th in Wilsonville, and we supplied that address on our Oregon Connection group. We'll keep posting out about it and make sure everybody we need is 3 times as many people hopefully showing up at that meeting. We have early in the morning on August 9th, we have the Value-Based Benefits Subcommittee meeting. They're a subcommittee of HERC, and they're going to be looking at the chronic pain task force's proposals.
and then giving its recommendations to her in the afternoon on August 9th. We've been told that we can comment now until July 30th. And tomorrow we're going to have all the information out on how you can comment. And if we can do more, we'll supply that information we can put it out. So this needs to be a monumental effort. It's not even just to work on this, but nationally. Thank you.
Okay, Todd, I want to get some more details. For those of us that are new to the issue, when is the cutoff?
It's a hard one to answer. It could be as early as this October. Their goal is to get every Medicaid patient, Medicaid member that's on opioids off by 2019. 2020 is their long game goal. If it's approved by HERC on August 9th, the draft policy by the Chronic Pain Task Force, then it will simply just fly and it will go. And even when it's just something that's about to happen, they'll implement it everywhere. So we can expect it early in October if we're not too sure.
They're going to start heading the opiates right away. As far as I can see what I've read online, is that they are going to head into the gun.
But they're going to do the forced tapering. I'm pretty sure that the rest of it they're going to vote on later, but the forced tapering they say is already too late. They need to get it done right now, so I don't know. See how this goes. Comment on the Oregon Pain Management Group. There's posts there about commenting on the proposed changes. So go there and make sure that you get your comments in, and they need to be specific to the changes too that they're talking about. Don't talk about other things, because they'll discount your comments. So stick to, yeah, I did a little sample kind of thing with questions in there, with some suggestions that people can try, you know, so, but keep your comments specific to having your opiates taken away and how that affects your quality of life. It would be the best thing to do when you're in started and what injury it is, just the diagnosis. Don't go on and how it affects you, because they don't want to know that. We just need to keep it to that. Okay, thank you.
Well, and also ask your neighbor that's known you for a long time, ask family members to comment, so that it doesn't just have the chronic pain patients, but our whole community of neighbors and friends and family.
And I just wanted to clarify what I discovered. I started my own advocacy 3 years ago because I have been on the Oregon Health Plan for I think about 8-9 years now. And I started attending the Oregon Pain Management Commission meetings, which is also under the Oregon Health Authority, about 3 years ago, specifically because of Note 60, that's conditions of the back and spine, where they were going to remove all opioid coverages for people that had any back conditions. It was just blanket. Nope, you're not getting everyone off. But they still allowed exceptions. So that's actually started. That's been going on for 2 or 3 years now. But they would always allow exceptions for certain cases, such as mine. What this chronic pain task force basically was created to do is to take Note 60 and expand it to every part of the body, and then to take away exemptions. They did it in a very shady way, and there's still lots to be discovered about that. That was not ethical, in my opinion. But we have to still follow the rules of the commenting period, and all of us have to look at the best ways to do that, and we have to be very precise about how we comment, like you said. Thank you.
Yeah, I hope you don't mind, Amara, this informal interview I'm doing, because I want just lay people like myself to understand that you can clarify this. So this effort is to get people off their pain meds that they've been on for decades, and to get them on addiction cure medicine, and that they have to sign a waiver saying they are an addict and they need therapy, and it has nothing to do with pain, right?
I don't know much about a waiver, but yeah, once you're labeled that's you forever. You're red flag forever. You don't go back to being a chronic pain patient. You'll be an addict. Medical bullying is happening all the time right now, like Wendy said about her mom. This is going to be commonplace. And this last push, there's no other, I've been in contact with Dr. Stephen Cortez, and he's the one that worked on the CMS, stopping the hard edit from CMS. He is very in touch with everything going on in our country, and we know it's bad. But there is no other Medicaid state program that's going this far. This is the most radical that he has ever seen. And forced papers are unethical and medically dangerous.
Thanks for clarifying that, because again, we need to delink, because the opiate addiction of a grandson stealing his grandma's medicine and become an addict is a completely different issue than somebody who's been suffering chronic pain or illness for decades, right? So we just want to really make that clear that the other part of opiate crisis, that we support that effort to get people off of being addicts, but after you get on this therapy, what are we going to do for your pain, right? I mean, your pain doesn't go away just because you quit. So thanks everyone for coming and supporting their spouse. Did you want to talk, Sarah, about?
Thanks for the advocates.
Yeah, and for family members sticking together, keeping with your family and not abandoning your family. That's so important. So I think we're wrapping it up, right? Julia, anything else? I'm glad that she's got the news there. Thanks everyone we'll tidy up and clean up, and we'll be back on August 9th, right? Yeah. Please keep your thing, keep it for August 9th, hang on to your thing because we'll bring it again, and just hang it on your doorknob if you have to, right? At home, tell your neighbors.